Hello, good afternoon. Thank you very much for the nice introduction, Dirk. And thank you very much for the invitation. It's an honor for me to be here today and talk about our research in Charleston and Columbia. Perfect. So I don't have anything to disclose personally, except that I'm presenting research that I think almost everybody here in the room has participated, and many of the people who might be listening to the talk. So I'm just talking about research that has been built upon a large and incredible team. Let me start with some background. As we all are aware, stroke is the leading cause of disability, is one of the leading causes of disability in the US, and 800,000 new or recurrent strokes occur every year. Many impairments result from a stroke. When we look at typical or impairments with high incidence, upper extremity impairments, lower extremity impairments are on the list, as well as swallowing disorders and language. Language disorders are often described that they affect 1/3 of all stroke patients. When we compare that to those other impairments that are listed here, these are actually, the incidence is lower compared to swallowing disorders, lower extremity or upper extremity disorders. However, when we then look at who's recovering from those impairments, language is actually again at the bottom of the list, but this time in the way that the majority of all patients who have language disorders at the beginning still have significant impairments 1 or 2 years after their stroke. And compared to other impairments, like for example, swallowing or lower extremity, they are more likely to recover if they suffer from those impairments. So our work on looking at recovery in aphasia after stroke is really important, because we deal with or we want to help a patient population that might not be able to recover without treatment. Why are there differences when we look at lower extremity, upper extremity, swallowing, language? Well, you might say this might be just a measurement issue. So looking at incidences often depends on how we measure it. That might be a reason, but more so probably neuroanatomical reasons. So for example, walking, swallowing is both a midline function. Both sides of the brain are involved in controlling, and other functions like upper extremity or language are more heavily lateralized to one hemisphere. So how well the remaining tissue can compensate for a specific function is different between things when we look at swallowing or language impairments. When we look at individuals who have language impairments, there are also differences how well they recover. And in my talk, I want to focus on how well the residual brain that is not affected by a stroke. Stroke is in this picture outlined with this black area. How well can the residual brain area not affected by the stroke can compensate for function? And this has been sometimes also titled with, like, for example, brain health. So Dr. Alex Basilakos has also some work there where we are looking at how healthy is the brain, how well can the residual brain compensate for an impairment. We are specifically interested in looking at white matter, how healthy the white matter is, and what type of white matter injuries might or might not be related to compensation. When we, for example, imagine to have a patient who has a stroke, in this picture on the left side, you can appreciate that the white matter underneath the lesion is damaged, so there are some tracts missing. I'm just displaying in this picture the longer range fibers for visualization purposes. However, not only the white matter under the lesion is affected, but also the white matter that is leading outside of the lesion to other areas, and that might then be negatively affected in terms of their function. And this is what we are more interested in, to understand outside of the lesion, what are the factors that impact if someone recovers or not. There has been some work so far to show that the residual white matter matters. For example, when we just look at the broader architectural structures, the macro structure, where Dr. Leonardo Bonnier and also Julius Fredrickson and the group here were able to show that the structure of the networks in terms of small worldness or betweenness centrality was an important factor to predict if someone will respond to treatment or not. When we then go a level more down and look from the macro a little bit in more detail to the microstructure, we also have evidence that specific tracts are associated if a patient responds to naming treatment or not. There has been some recent work from Meyer and published in this year from the group from Swati Kiran, who were able to show that to predict treatment response, the IFOF and the ILF microstructure integrity was important as a predictor independently of lesion volume. Then further, Emily McKinnon was able to show in a DKI analysis that also specific parts of the ILF are important to predict naming recovery. What we were interested in our recent work is to understand in more detail why there is this relationship between residual white matter and aphasia recovery. So we wanted to understand more about the neuropathology, what kind of fibers are there we might need to take into consideration. In this talk, I want to focus on long-range white matter fibers and indirect connections, indirect white matter connections. In the first study that we did to look at the impact of long-range white matter fibers, and we were very fortunate that we were published recently. So this is your reference to maybe read a little bit more if you're interested about the study. In the study, we aimed to look at the association between white matter damage, long-range white matter fibers, and recovery. So just to give you a little bit of background, white matter hyperintensities, as you can see, if I have the mouse, yeah, well, here, as you can see here, different stages of white matter hyperintensities. Usually, you can score those in a T2 or FLAIR MRI scan. In this brain, there are like little outlines here around the ventricles, and from here we have more areas, larger areas, and here quite severe white matter hyperintensities that you can easily score in those MRIs. And interestingly, about 95%, so almost everybody above the age of 60, presents to some degree white matter hyperintensities. Is it around the ventricles or in the deep white matter? So these are very common findings. It is often mentioned as one of the hallmarks for small vessel brain disease. And it's associated with stroke. Dementia is often a precursor for those diseases, as well as with comorbidity factors like hypertension and diabetes. In general, what has been shown is that these white matter hyperintensities, the more severe they are, the worse is the outcome after stroke. So this has been shown in general, stroke outcome in general, but also more typical for physical impairments, swallowing impairments, cognitive impairments, and also language impairments. For language impairments, Dr. Basilakos was able to show that actually when we see a decline in language performance after the stroke, there is an association with more severe white matter hyperintensities. What we do not know is why is there this association? So what exactly is the underlying neuropathology that that results in the relationship between white matter hyperintensities and worse aphasia or stroke outcomes? So this is what we were interested in to shed a little bit light on. When we look at the idea of the network architecture in the brain, we understand that it's not just a random network. So there's some sense behind how the network is organized in the brain. What is assumed is that there is kind of a balance between cost and efficiency. So it's somewhere in the middle between a random and lattice topology. So it's not that every region is connected with every other region. That would be too costly. but it's not that just one region is connected to the other, because that would be really low efficiency. So somewhere in the middle is this this sweet spot. And what has been discussed is that this proportion between short-range fibers and long-range fibers is very delicate. Long-range fibers, of course, are kind of like a shortcut. If you want to travel from one area to a distant other area, long-range fibers are really helpful. However, to maintain these long-range fibers, it is more metabolically demanding than short-range fibers. So long-range fibers support the efficiency of communication, but are more costly in terms of maintaining these structures. So we hypothesized that white matter hyperintensity, so damage to the white matter, will be associated with a higher proportion of damage to long-range fibers instead, compared to short-range or middle-range fibers. So because they are more metabolically demanding. And further, we hypothesized that this will explain why we see the relationship between white matter hyperintensities and worse aphasia outcomes. So that the preferential damage to long-range fibers will be the mediator to explain this relationship. For this study, we analyzed 48 individuals with chronic stroke, chronic left hemisphere stroke, around 60 years old. And here in the bottom, you see the lesion overlay of all 48 patients. Warmer colors represent more patients with a lesion in that specific area. So it's typically here also around the perisylvian area in the left hemisphere. Our assessments were as follows. For the independent variable, we were interested in the severity of white matter hyperintensity. So we looked at periventricular hyperintensities and deep white matter hyperintensities. Our outcome variable, the dependent variable, was aphasia severity, and our mediator variable was fiber length. So we were interested to see if the effect from white matter hyperintensity on aphasia was mediated through a decline in long-range fibers. This is how we scored the hyperintensities. So we only looked at the right hemisphere for the hyperintensities because the patients all had strokes in the left hemisphere. So we focused on the right hemisphere to get a score for the degree of hyperintensities so that the stroke lesion doesn't interfere with our scorings. We used the Fasekes scale that has been commonly used in literature looking at white matter hyperintensities, and it's a 4-point ordinal scale ranging from absence, so no white matter hyperintensities, to confluent areas. In the picture here, in the figure, you see an example in the first row of a patient who does not have any white matter hyperintensities. On the left side, again, there's a stroke, and we only look on the right side if there are any white matter hyperintensities. In the lower row, there's another patient. That is an example of a patient with severe white matter hyperintensities. They are highlighted here in the turquoise color. This is a quick overview of the distribution of all the scores for the periventricular and the deep white matter hyperintensity scores. And as you can see, for the periventricular hyperintensities, we had a nice distribution across all the 4 scores. For the deep white matter hyperintensities, most patients were scored with a 1, so there was a heavily skewed distribution over there. For the MRI analysis, we used the T1 for the normalization and registration into standard space. T2 was used to manually draw the lesions and for the white matter hyperintensity scoring. And diffusion tensor image was used to perform pairwise probabilistic tractography. In our analysis, we used the number of streamlines connecting each pair of regions as the weight for each link. So it was not a binary score that we used for the tractography. It was a weighted link. For the fiber length, to determine if it was a short range, middle range, or long range fiber, we calculated the Euclidean norm between each pair of possible ROIs in the entire brain in a standard MRI and classified those within the first quartile as short, in the second and third quartile as median long, and in the last quartile as long fibers. And then we analyzed or calculated the connectome for each patient separately, and then based on the norm brain, we then classified all the fibers in the brain from patients if they were short, middle, or long range. We performed Spearman correlations because our data was not normally distributed, most of it, and then we performed a parallel mediation analysis that I will talk more about now. So these are our results. First of all, we found significant correlations between higher white matter hyperintensity scores, so worse white matter hyperintensities, and a lower proportion of long-range fibers. So the worse white matter hyperintensity, the lower the proportion of long-range fibers that you can see in the figure on the right. Here are the scores of periventricular hyperintensities. 3 is the worst score, and the proportion of short-range fibers goes up, and the proportion of long-range fibers here goes down. So we found the same, but on the reverse direction for short-range fibers that then went up compared to long-range fibers. This is an example where I think you can appreciate the relationship between white matter hyperintensities and the fibers. Again, the first patient has hardly any or no white matter hyperintensities, and when you just focus on the right side of the reconstruction of the tractography, it's a dense, very dense tracts, very dense connections. In the patient with severe white matter hyperintensities, on the right side, lots of connections missing that we don't have in the other patient, and the right side is spared by the lesion, right? So there's no lesion on the right side, and you can see the differences here in the connections. For the mediation analysis, what we found is that there was a significant total effect of periventricular hyperintensities on aphasia severity that we measured with the Western Aphasia Battery Aphasia Quotient. So that was significant. When we then looked if that was actually a direct association, we found a trend, but it was not significant, as you can see here with the confidence interval that included 0. So a total effect, yes, but the direct effect was trend, but not significant. When we then looked at the indirect effects, we found a significant effect of long-range fibers as the mediator between periventricular hyperintensities and aphasia severity, meaning that the higher the periventricular hyperintensities, the lower the proportion of long-range fibers, the worse aphasia severity. And on the other side, it was counterbalanced by an indirect effect between higher periventricular hyperintensities were associated with a higher proportion of short-range fibers that then was associated with worse aphasia severity. So to summarize our first study, we found that white matter hyperintensities, in our case periventricular hyperintensities, probably predispose a stroke survivor to worse aphasia because of the damage in long-range fibers compared to long-range fibers or mid-range fibers. And again, this might happen because the long-range fibers are especially metabolically demanding, so they are more prone to be damaged when there are any lesions or hyperintensities. Now we continue to the second study. So our first aim was to look at the contribution of long-range fibers, and the second aim was to look at the importance of indirect white matter connections. So as many studies and lots of evidence has suggested already, is that white matter connections, pairwise connections, so direct connections between two regions, are important to predict language outcome, to predict recovery. Based on what we understand how the brain is organized, so when we think about, for example, small worldness structure, not every region has a direct connection to another region. So there will be some regions that are indirectly connected to another region. What we do not know is if these indirect connections are important for recovery. What has been suggested is that these direct and indirect connections that exist in the brain might really serve different functional roles. Back, I think, 15 years now, Catani and colleagues published this paper where they looked at the connection between Broca's and Wernicke's area. They were interested in the acute fasciculus, and they pointed out that yes, there are direct connections between Wernicke's and Broca's, but there is also an indirect connection between these areas, and they speculated that the direct and indirect connections probably serve different roles during language functioning, language processing. So our question was, can indirect connections support aphasia recovery, or can language improvement only be mediated by direct connections? So when you think about region A and B might have lost the direct connection, but there's still an indirect connection through an intermediary node C, they might still be able to communicate or transfer information. Is that enough to explain recovery? And I want to think about this a little bit like something commonly happening in Charleston, where there's often flooding on the streets, and I'm using my bike in downtown Charleston, and flooded streets are kind of like a loss in connection, but you need to work hard to find the indirect connection and can still get to your goal. So our objectives for this second study were to determine the impact of indirect connections on treated aphasia recovery, so response to treatment. And second, to determine if the number of steps, so how many intermediary nodes are there between the two nodes, if that matters in terms of recovery. And then we were interested in to see where actually these indirect connections go through in the brain, where they pass. For this study, we recruited 69 individuals from the study that Dr. Fredrickson published last year on the futility of TDCS in aphasia. So if you want to read more about this study sample, this is a good reference. These patients all had left hemisphere strokes, were chronic, and they had 3 weeks of aphasia treatment. And we were interested to look at the aphasia status before and after treatment. So if we can predict, or if we can understand who's responding and who's not responding based on the Philadelphia naming test. We looked at the change, improvement, or decline in correct responses from baseline to follow-up, and in semantic errors. A note here in this study, the semantic errors were not scored on the first, but on the last response. This is an overview of the performance in the PNT from this patient's cohort. So for example, like all patients on average named 58 items correct at baseline, and on average they improved by 5 items after treatment. Semantic errors were about 13, 14 at baseline, and then they produced fewer semantic errors, about 1.3 after treatment. Again, we used the T1, T2, and diffusion tensor imaging as we did in the other study. And we adopted a method that has been previously published and used by the group of Bratislav Misic in Healthy Brains, where they wanted to better understand how the information is spreading in the brain. So when one node is active, how is the information spread through the entire brain? John Delgasio and Grigory Yurganov, they've first applied this method to stroke patients, where they wanted to understand if these, like the spreading in the network, so also like looking at indirect connections, if that helps us to understand language performance after stroke. And they found out that using traditional lesion symptom mapping together with conic term lesion symptom mapping, so looking at direct links and looking at these indirect connections, was actually the best setup to predict aphasia severity. So it did have a benefit to look at this information spreading, these indirect connections. We used it as follows. So this is our method, how we determined indirect links. A direct link was everything that was higher than 0. So we excluded spurious connections here. 20% of spurious connections were already set to 0. And then everything above 0 was determined as a direct link. If there was no connection, so when the link was 0, everything was labeled as no connection, and an indirect connection was anything that was above, that was not a direct connection but had an intermediary connection. So when you look at these figures here, and we are interested to look at the regions between seed and target. In the first figure, there is a direct connection, and in the next figure, the direct connection is lost, but the regions are still connected through 1, 2, 3 other regions. So the step length, the number of steps you count to get from region 1 to region B is 4 in this case. We selected 3 regions for this analysis. It has, of course, advantages and disadvantages to just look at the subset of regions. We selected language hubs that had been proposed to be especially engaged, important in language processing. And we chose regions that were distant from each other because we were interested in indirect connections. And when we were looking at just like regions that were directly neighboring each other, it was unlikely that we find any indirect connections. So we purposefully chose distant areas that are likely important for language. Let me see. Here we go. So this gives you an overview of how often or how many patients had direct, indirect, and no connections between these 3 regions. So for example, between the inferior frontal gyrus opacularis and the angular gyrus, about 20% had a direct connection. 66% had an indirect connection, and about 10–11% had no connection. So this sums up to 100. So if a patient had no indirect connection, we looked if there was a direct or a no connection. And for the statistical analysis, we first performed an ANCOVER because we wanted to understand if the connection type matters. So does it matter if these 2 regions are directly connected, indirectly connected, or have no connection? So we wanted to first see, is there actually an effect of the connection type? And we controlled for many variables that we think were important, like age, baseline WOP IQ, education, lesion volume, and also the regional lesion volume of the regions that we were looking at, and also direct connectivity. And our outcome variable that we wanted to predict was a change in correct naming or the change in semantic paraphrasias from baseline to follow-up. For the second aim that we had in the study, we looked where we wanted to look if the number of steps make a difference. So if it's a short indirect connection or a long indirect connection, we performed a multivariable linear regression modeling. Again, the outcome was the improvement, and the number of steps was the main predictor, and we also used all the control variables as we did in the first analysis. And third, we were interested to look at where actually these indirect connections, if they exist, lead through. So we counted frequencies and mapped those on the brain. So these are our results. First, where we were interested in to look at the impact of the connection type, we found a significant impact in the change in semantic errors. We didn't find anything significant for correct responses. So I'm only talking from now on about semantic errors. What we found was that there was a significant main effect for the connection type between the inferior frontal gyrus opacularis and the middle temporal gyrus, and between the middle temporal gyrus and the angular gyrus. So it mattered how these regions were connected to then predict treatment response. We performed a post-hoc test corrected with Bonferroni and found that patients with an indirect connection recovered or responded to treatment significantly better than patients with no connection. Then when we were interested to look at the number of steps made a difference, we did not find anything. So it didn't matter if these regions were connected indirectly through 2 or 3 nodes or just 1 node. Why was that? I suspect that it's probably because we didn't really have a huge spread of the data. So most indirect connections that we looked at were just with 1 region in between. So there was just 1 more step than a direct connection. So that might be that we couldn't really look at an effect of the number of steps because everything was more skewed towards the 1 step in between. Third, we were interested in looking at where these indirect connections lead through. And this is what we found. In red are always the regions that we seeded. So these were like the start and end regions. And we looked at the indirect connections between those regions. In the first figure here on the left, it's between the inferior frontal gyrus and the angular gyrus. The more green the color, the higher was the proportion of patients using this region as an indirect connection. So for example, in this figure, about 40% of all patients had an indirect connection that went through the motor area here, the motor cortex. In this figure, you see the pathways for indirect connections between the inferior frontal gyrus and the middle temporal gyrus that went mostly through the insular, but also the primary motor cortex. And here are the indirect connections between the middle temporal gyrus and the angular gyrus that primarily here went through the posterior temporal part of the brain. So to sum up what we found in our second study, we found evidence that indirect white matter connections between language regions were associated with treatment-related naming improvement in aphasia for semantic errors. So we didn't find anything for correct naming. Why that is the case, why we didn't find anything with correct, of course remains to be speculation. It might be that correct naming was a too coarse, too broad measure. As you might recall, for example, the work by Catani et al., they were looking at really like fine-grained differences in the role and the functional role of direct and indirect connection with, for example, semantic and phonological processing. And correct responses might be too broad because they could be influenced by many different processes, language processes. Further, we did not find that the number of steps mattered to predict recovery, and that might change if we would pick different regions in the brain, or it might really not matter as long as regions are connected, that this then predicts recovery. If indirect connections were present in the brain, they primarily involved the perisylvian areas. So mostly these were the areas that were proximate to the areas that we were interested in, but also mostly sensory motor integration areas, but then for the middle temporal gyrus and the angular gyrus, also associated cortex regions. So let me conclude with what we found or what we want to speculate about. We think that our findings, our research, suggests that recovery is likely better if long-range fibers are preserved in the residual white matter. Again, language, as we know and as we all appreciate, is very complex and relies on the broad neural network. And long-range fibers are those shortcuts where information can be fast and effective, transported from one region to the other, even if those regions are distant from each other. But again, these long-range fibers are metabolically demanding, so they are probably the first fibers that unfortunately decline if a lesion is present or any damage is present. Recovery might also be better if indirect connections are preserved. Especially in the case when a direct connection is lost and an indirect connection is still present, the communication between these areas is maintained, and that might then be a helpful predictor to understand if a patient is responding or is not responding to treatment. So for those patients who lost the direct connection, the indirect connection might be the explanation for treatment response. And maybe this is something for the future, indirect connections might be helpful biomarker for treatment responses. So that remains for further investigation. Some thoughts about how could we use this information clinically. It might be that long-range white matter fibers should be the target for us when we want to work preventively. So there should be a target, for example, to foster better outcomes in individuals with white matter hyperintensities, like blood sugar control, hyperintensity control. So everything that could improve the health of the white matter, the health of the brain, could then also directly actually improve the maintenance of long-range fibers. And maybe the indirect white matter pathways could actually be a target for treatment. So if we better understand where these pathways lead that are important for recovery, we could maybe foster these indirect pathways through neuromodulation or through other treatment approaches. So with this, I want to thank everyone who is involved in this research, and it's a lot of people who are involved in this research. First of all, of course, the C-STAR group. Many of those are here in the audience, and I was fortunate that I was able to present some of the work that I presented here today in Helsinki at the SNL. It was a great experience for me. And of course, I want to thank the Bonilla Lab in Charleston at MUSC and my mentor, Dr. Leonardo Bonilla, who is the main head creator from all this research that I presented today. And last but not least, I want to thank for the research support that we actually have. Thank you very much.
Thanks a lot. So we go to questions from the room first.
Have you also looked at the number of paths between two lesions and whether there is any explanation to the better recovery or faster recovery? I know that you look at the number of steps in between and you didn't find any connection. But I was wondering maybe the shorter paths also affect the faster recovery somehow or not, or whether there exists other studies that somehow provide some evidence for this.
So, yeah, so the question was if we also looked, so we did look at the number of steps between two regions, but if we also considered to look in more detail, for example, at the distance of those steps, or in any other way, if we were able. And the number of possible paths. So, or if there has been other research to show if that has any association with recovery. So, to the best of my knowledge, I don't know of any other research that has been looking at recovery. And we did not look at anything else than the number of steps. So we did not determine if the steps, for example, were depending on a distant, on a long range or a short range connection. So that would be something great to look at the next step. We also, for example, did not look at how healthy was this remaining link, right? Is it, maybe there was some damage to that connection or not, so we did not take that into account. So that was, what we did was the first approach to look, does that matter? Is that something we should look into it? And also the other question, so it could be very likely that there are multiple indirect pathways, not only just one indirect pathway. And we did not determine if that made a difference. So we just looked at, is there an indirect connection? Yes or no? And does that matter compared to those who do have a direct connection or who have no connection? So there are many, many ways where we could go in more detail. And I thank you for that question to see if there might be more effects. Yeah, future work with Grigori.
Sorry, did you run that analysis, you know, that from the second part, was it on with binary graphs or like
no, so you mean the tractography? No, so the tractography was the same. The values that we used were the same as in the other studies, so where we used the weighted links.
okay.
And so what we did is that we tried to exclude spurious connections. So it was based on probabilistic tractography, and we tried to exclude spurious direct connections based on, we looked at the right hemisphere as the supposedly healthy part, set a threshold of 20%, and everything below 20% was our cutoff to set everything to 0. So 20% of those connections we just set as to 0 to hopefully exclude most spurious connections. And then we used those weighted links to determine if there was a connection, if there was an no connection, or if there was then indirect connections. But as suggested, so we didn't look any further how healthy or how strong that connection was. Does that make sense? Oh, I think to just repeat, so the question was if we looked at binary tracts in the second study or if we use weighted links. I think Lisa?
This is kind of a similar question. On the slide where you showed the indirect paths and the more green the area was, the more likely they were using it. Is that more just saying the more the individual is to have that intact, not necessarily that they're using that pathway, but that it's intact?
Exactly. So you point to a really, really important point, and I'm thankful that
you mentioned that. So we only used structural MRI. We didn't use functional MRI. So we only looked if there is a possible connection between these areas. Do they really use that way to communicate between these two areas? We don't know. So we found that there is an effect of these indirect connections through these areas on response to treatment, on recovery, but we don't know from this study if that is really the way, the path they use. So a really nice follow-up would of course be to correlate that or see if that somehow fits with activity in the brain. What would be a great future study. Yeah?
Great presentation, Janina. Thanks a lot for sharing the data. I was really intrigued by the slide that you showed, that those patients who actually were capable of recruiting the motor cortex as an indirect pathway for making connection between those lost tracks were the ones that actually showed better performance on your language task, right? So I was thinking in the context of the sensory motor integration system, the dual stream network, it might be the case that those patients who are capable of maybe somehow reorganizing the neuronal map of the motor cortex into something being more oriented toward sensory motor integration, that is classical rule of just activating muscles for speech production, are the ones who actually show more successful performance for language production. So first of all, I just want to know if you have any speculations about the role of the motor cortex in these patients, the ones who actually show better performance. And also second, we actually have a lot of data using the sensory motor integration task, the ultraradiatory feedback paradigm, that some of these patients actually may have overlapping data. And it would be interesting to see if lesion to the motor cortex area might be actually a predictor of their performance, just based on what you're showing, that the ones who actually recruit that region as a hub or an interface or connection are the ones that actually succeed in the language task. Or something else.
That's a great question.
Can you repeat that question?
The question was that as we show, when we look at the pathways where the indirect connections go through, most of them or some of them went through the sensory motor integration areas, for example, the primary motor cortex. And so the question idea is, what is the role, or how does the motor cortex might play a role in recovery, in language recovery? And then the second part of the question was that actually some of these patients in the study might actually really had also speech and auditory feedback, EEG analyses, and so we might be able to correlate that if improvement or plasticity in the motor area taking over more language functions might be the reason why we see this association. So now we come to the answer, to speculation. So of course, we just have to keep in mind that there is this connection, structure connection, but of course it's all speculated that if really the motor cortex is recruited, is active, right? So first of all, my first thought is that, so we use the Johns Hopkins University Atlas, and it's quite a coarse segmentation, right? So we don't really know where along this the region is really the connection to the fibers. We did control for regional lesion volume to see if that is an independent effect, and it was an independent effect. And I remember some research that showed that actually the motor cortex is involved in language processing. So not only in speech articulatory processing, but for example, also when we listen to language, that we have an afferents copy, etc. So that the motor cortex, I think, is probably underestimated to just be motor, what the name implies, but that it has more roles than just motor execution. And I think what I like about what you pointed out is that maybe when we see the path along the motor strip, it's also underneath what we believe it's the dorsal stream, right? So maybe that is also something that we should think more about, which area in the brain should we try to amplify to recruit to have better outcome. And here it was the sensory motor area that we might not immediately associate with semantic improvement, but that has been shown sometimes to be also included there. So I think that there is no answer yet to what it is, but I really like the idea to correlate that with activity in the motor cortex with other functions, if that has an impact on recovery in language. So I like the ideas of future collaborative research here. And if someone else has an idea, please help me out here. Dr. Fredrickson.
Thank you. That was fantastic. I really appreciate you also working on this data set. It took a very long time to collect these data. We've only published the main results and some secondary analysis. I'm really glad to see that. A couple of questions just for clarification. The first one had to do with objective one, so the ANCOVA that you ran. You said you controlled for direct connectivity. It wasn't clear to me how you did that.
So the question from Dr. Fredrickson was for the second study where we performed an ANCOVA. One of the control variables was direct connectivity, and how did we do that? So for the control variable direct connectivity was the weighted link. So if there was a connection between these two areas, I put the weighted link between those areas into the model as a control variable, because so one of my thoughts, or our thoughts, was that there's a lot of debate what factors actually contribute to recovery, right? So for example, some work has been just recently published that there might be just a regional damage. There might be actually that the direct connection we should not pay a lot of attention to, they don't do a lot. Then maybe there's the indirect connections that are especially important. And I wanted to see if the indirect connections, independently of all these other variables that we think have an impact on recovery, have an independent effect. So the indirect connection independently of the regional lesion volume of those areas, independently of the entire lesion volume, independently of age, education, independently of this direct connection. So does it help us to explain more of the variance than just those variables?
Did you look at whether the actual direct connectivity does predict outcome?
So I did I did do that because when I, for example, also ran like multilinear regression models, I was able to see what factors actually or what predictors were important, and hardly any of the connectivity links were important. The regional lesion volume was important, but often also the indirect connections were important. Something else, so beside all these like structural markers, what was important was the baseline aphasia severity. So WOP-IQ was is probably not too surprising, but a very, very good marker if someone recovers. And yeah, and it's sometimes frustrating as to when you run statistics and you put WOP-IQ in. Yeah, so this like explains the highest variance. Age was a predictor for semantic errors, and don't recall out of my head in which with which indirect connection, but TTCS was significant for one analysis that I ran for semantic errors. So that was interesting to see.
So I can't remember off the top of my head. So there was the statistically significant difference. So just the t-test pre-post, improvement in correct naming, and reduction in semantic errors, but nothing for phonological, right?
So I did not include phonological errors here based on your suggestion a couple of months ago.
Yeah.
Because
they didn't change. They were the same before.
And phonological errors were really were not often, didn't occur a lot. So I think there was like an average of 3 or 2 phonological errors percent. So I did not look further into that, but when we just ran a t-test without controlling for everything, there was no significant difference. But when controlling for WOP-IQ and TDCS, etc., there was significant difference for correct naming.
Yeah. And I can't remember whether there was a correlation between the reduction in semantic errors and increase in correct naming. I can't remember. It was a while.
I don't know.
No.
But yeah, also what I did not do in this analysis is, for example, to look at the potential for recovery. So the outcome that I've used here was really like what was the raw difference. Yeah. And I think a good idea is, for example, what Maya et al. 2019 just did is to look at how much can actually a patient improve. And so I controlled for baseline aphasia severity to kind of get a hold of that, but I think there are many different ways how we can probably better estimate the potential recovery.
Still very controversial.
Yeah?
Yeah.
I had a question regarding your classification of the patients. It seems like if they have a direct connection, then they will not fall into the category of indirect connection. They fail to fall there because everything adds to 100. So there is no sort of distinction of those who had the direct connection plus indirect and direct connection alone or standing indirect. So is there any possibility of that affecting your outcome?
So thank you very much
for pointing that out. So the question was that how we set up the analysis, patients summed up to 100% for direct, no connection, and indirect connections. And those patients who have a direct connection might also have indirect connections between those brain areas. And we did not account for that because when they did have a direct connection, they did not fall into the category of indirect connection. So absolutely. And so this was a decision that we made, because we assumed that a direct connection will be the best case scenario. And that then if no direct connection is existent, then the indirect connection will be the next better scenario. And if that doesn't exist, the no connection is kind of the worst. So this was just one attempt to get a hold of the data. But there's definitely, for example, another way could be in statistical modeling to have patients, do they have a direct connection, yes or no? Do they have an indirect connection, yes or no? How many steps did you have everything as separate variables in the model? Because this was the first attempt of us to use that to understand if indirect connections is something that we should pay more attention to, that was one attempt we did.
Okay, just to build on the other person who asked the question regarding plasticity, do you look at the profession of the individual or the occupation? Because I'm thinking those who are, let us put it, excessively articulate professions like journalists or people like us, who are, so it's or teachers, school teachers, is it possible that their profession might alter the plasticity that's going on, and do you all control for that?
So the question was if we somehow took into consideration the profession. So if someone who is more literate, more educated, has an occupation that is more demanding, maybe also language-wise, speaking, talking, if that might make a difference in terms of who's recovering and who not. So this is the question that I might also need to open up to the audience. So what we controlled for is education. So education was here modeled as the number of years that a patient went to school. So of course this is just a proxy for education, and we used that as a control variable, and it was not a significant predictor. I did not take into account if that patient was still occupational involved, so what before the stroke, what the occupation was. So these are things that I can imagine definitely have an impact. So it's also when we think about brain health and how well the brain can compensate for an injury, I think it's very well possible that someone who used the language a lot, or is still using the language a lot, is relying a lot on communication, might have a better residual network to use to compensate for damage than someone who's not so much relying on language before the stroke or after the stroke. But please feel free to share your experience.
We do have a question from online as well.
Okay.
Maria Ivanova says, great work. In the second study, have you considered classifying whether the indirect connections went along the ventral or the dorsal pathways, and whether that might be a contributing factor? Possibly one of the pathways might be more central to recovery of word retrieval ability.
Thank you, Maria. So that is something that I did at the very beginning. So when I presented the work at SNL, and actually Maria and we talked about that as well. So I've looked at like the ventral stream at a whole, and I looked at the dorsal stream at a whole, and was counting if there are indirect connections, how many steps, etc. And in my very first models, just looking at the number of steps, propagation speed between the ventral stream was a significant predictor for correct naming response, for semantic errors. The dorsal stream was also a significant predictor, controlling for all the variables that I mentioned. However, in the moment that I controlled for total lesion volume, that predictor went non-significant. So that was something that I added later on. And so in this case, when controlling for total lesion volume, the indirect connections within one stream were not significant anymore. But again, that might be something we could think about or discuss how to model that better, how to take that better into account.
I noticed that you had an ROI in the MTG, and that was a little bit odd place to put it. I guess you put it because you wanted to cover the anterior temporal lobe as one of the hubs, but you only use the MTG. So there is the superior longitudinal fasciculus and the inferior. So does this ROI cover both of those pathways, or only one of them, or you don't
So why we decided for these regions, it was, of course, it was more an arbitrary decision, right? So we wanted to look at regions that we believe are important, and in Dr. Fredrikson's work, Anatomy Revised, he suggested that there are a couple of hub regions, not only those three that we chose. There were also like the supramarginal gyrus was important, the inferior frontal gyrus triangularis was a so-called hub region, and we selected those regions just to make sure that we have distant areas, so that they are not neighboring areas. That's why we chose the opicularis, middle temporal gyrus, and angularis to have the possibility of many regions in between as indirect connections. So it might make a difference if we would choose other regions. So I totally agree. It might be that we just didn't choose the right set of regions to look at indirect connections, to look at an association for correct naming, for example. So our study just probably can say for this set of regions that we looked at, the indirect connections seem to matter for semantic improvement, but not so much for correct naming, for change in correct naming. And I agree with you. For example, if you would maybe look at the posterior superior temporal gyrus to the inferior frontal gyrus, that might make come up with different findings.
The entire anterior, so the superior temporal ATL, but the superior part as well as the inferior part in the anterior temporal, because they can also have an important.
Exactly. So,
and I think, as we probably all are aware, there are many debates of regions, which regions are important, which regions do what. And so this was one way to look at some regions that have been frequently associated. But I agree with you, there might be other regions. And then your other question was if the middle temporal gyrus, was that probably involved in the inferior longitudinal fasciculus or in the IFOF? So of course, the middle temporal gyrus, as we segmented it here based on the JHU atlas, is only the gray matter. The inferior frontal gyrus would go underneath, but it's very likely that maybe the indirect connections or the direct connections go through this fiber tract. But that was what we didn't classify, if these indirect connections went through what tract. So we only looked at these pairwise connections, and that might be also what Maria was pointing to. If we looked at these indirect connections, through which tract did they really go? We didn't do that yet. So that's also a lot more opportunities to understand the data better.
In your analysis in both studies, you regress out the size of the lesion, and I was just wondering how your results interact, or the facts interact with the site of the gray matter lesion. And there's two parts to that question. One is there any reason to think that the presence or the severity of leukoariosis might be predictive of particular types of lesions? So are particular sites of lesions, predicted by leukoariosis? Another one is not every gray matter region, or ROI in your case, has a similar amount of long fiber tracts that sprout from it, right? So by definition, if you have a lesion in an area A that has a lot of long fiber tracts, then you're going to get damage to a lot of long fiber tracts, versus area B that doesn't have that. But so are your behavioral data then accounted for by the gray matter damage or by the fiber tracts? How do you think about that, or how
So what we would assume is that what has been, for example, shown is that when you follow patients with white matter hyperintensities longitudinally, so you look at like if they are more severe and if what fibers will be affected, it seems there was some evidence, and I cannot recall out of my head the name of the lead author. There was some evidence that especially the long projecting fiber tracts are affected with longitudinally, with more severe white matter hyperintensities, preferentially have an impact on the integrity of these long projecting tracts. So what we did not do in this analysis with the white matter hyperintensities is to look at specific sites. So we just looked at, are there white matter hyperintensities anywhere? Is it periventricular or is it in the deep white matter? And actually, Lisa, who is sitting here, she scored most of those, or all of them. So this is something, of course, that would be interesting to look at if the location of the white matter hyperintensities matter in terms of outcome, or in terms of what fiber tracts will be affected, and also like the volume. So a 4-point ordinal scale is only as detailed as it can be, but the volume of white matter hyperintensities might be a better explanation.
I was actually talking about the site of the gray matter damage.
Of the gray matter damage with the white
That's
matter
where
hyperintensities,
yeah.
or
well, with the white matter hyperintensities, that's only restricted to the white matter. But did you mean the stroke lesion?
Yes, exactly.
The stroke lesion.
So
the stroke damage. Okay. So in that particular study, we did not include the site of the lesion as a covariate. We only included the lesion volume. So the total lesion volume was a covariate also in the mediation analysis, but we did not take into account where specifically the lesion was. Definitely that could be a factor. Was difficult because in that study we had 48 participants, so you somehow can only control for so much, even so you would like to control for a lot more. But yeah, it's a good thought.
So in terms of this, do you think that possibly therapies could be developed to help target these indirect connections, maybe possibly through some sort of multimodal therapy to help facilitate language recovery afterwards?
So the question was if I believe that based on these indirect connections, treatments could be developed to target those indirect connections. And my question is, I would hope to see that. So do I believe that? I believe we can achieve that. So I would, and of course, the answer is I don't know if this will happen. First, we need to better understand if that is worth it. So should we aim? Can we somehow do that? But I believe I can imagine that if we better understand which pathways are those that respond to treatment, then we might can come up with neuromodulation techniques, for example. Or if we understand, hey, we should focus more on the sensory motor integration areas to be involved in the connections, we might can come up with specific treatment approaches that target these functions to promote the involvement of these tracts. So not only neuromodulation, but then maybe, for example, we could see, like, should we more focus on the dorsal connections to see better outcome in specific patients? That might be something we could think about.
I think at this point maybe we should let Janina off the hook and feed her and give her a round of applause.